Then Dr. Michelle Morse is representing Dr. Ashwin Vasan, both in a voting capacity. So let me begin with the approval of the minutes from the last meeting. Okay, so all in favor, please say yes.
Yes.
Those say no. Minutes approved. So executive session. So during the executive session, the board received and approved oral and written governing body submissions from NYC H&H Woodhull. The board received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Kohler Long-Term Care and Gouverneur Nursing Facility. And the board also received and approved semi-annual governing body 2022 Performance Improvement and Evaluation Plan written submissions from NYC Health and Hospitals Cumberland, Gotham Center. Let me move on to the next item. So according to Article 6, Section C, appointment, the chair of the board shall annually appoint with the approval of a majority of the board, members of the board to the standing committees. I would like to propose a motion to appoint Sally Hernandez Piñero to the executive committee. Any questions? So all in favor, please say yes.
Yes.
Let's opposed say no. So appointment approved. And then the second one is, according to Article 6, Section 1D, committee chair, the chair of each committee, both standing and special, shall be designated by a majority vote of the board. So I would like to propose a motion to appoint Jose Pagan as the chair of the Capital and Strategic Planning Committee. Sorry for the awkwardness on
Is
this.
he in favor?
It's a lot more meetings. So, any
Might not
questions?
be in favor.
That's what I was thinking. He might vote no.
Exactly.
All in favor, please say yes.
Yes.
All say no. The motion
I
carries. Next on the agenda is the adoption of the minutes for the Board of Directors meeting. I'm sorry, I already did that. I'm sorry about that. Let me move on to the next item, which is Vendex approval. Since we began the process of approving contracts prior to Vendex approvals, there are 6 items on today's agenda requiring Vendex approval. 4 have that approval. There are 2 items from previous board meetings pending Vendex approval. Since we last met, 1 approval was received. We will continue to notify the board since Vendex approvals are received. And I was going very fast because we have a lot of resolutions to discuss. So, of course, I welcome questions, but at the same time, keep them to the point. So let's get started on that. So we begin with item number 6 in the agenda, which is adopting by the Board of Directors of New York City Health and Hospitals Corporation the system pursuant to Article 57A of the New York State Arts and Cultural Affairs Law, the applicable provisions of the retention and disposition schedule for New York local government records, issued by the Commissioner of the New York State Education Department, as revised by the Systems Records Management Governance Committee for use by all workforce members in legally disposing of system records. This was presented directly to the Board of Directors, 9/28/2023. So, go ahead.
Good afternoon, everyone. My name is Catherine Patsos. I'm the Chief Corporate Compliance Officer. With me is Karen Wilkinson, the Deputy Corporate Compliance Officer and Corporate Records Management Officer for Health and Hospitals. So because New York Health and Hospitals is a public benefit corporation, it meets the definition of a local government under Article 57A of the New York State Arts and Cultural Affairs Law. Therefore, as a local government, it is required to adopt the local government retention schedule known as LGS 1. LGS 1 was issued by the Commissioner of the New York State Education Department, and it describes the types of records created or held by local governments and their associated retention requirements. Next slide. So currently, our record retention program, we are working on reducing the amount of paper storage that we have at Iron Mountain, our vendor. and as part of that, Karen in particular is working with the facilities to destroy paper records in storage that are beyond their record retention requirements so that we can reduce our storage costs. We also initiated a scanning program in conjunction with the office moves to this building in compliance with our electronic record requirements. Under the Arts and Cultural Affairs Law, a record can be reproduced in any way that accurately and completely reproduces all the information in the record. Then the original record can be disposed, provided that the reproduction process and preserving the copy, the examination of the copy meets the requirements of the State Department of Education. And thereafter, the reproduced copies can be used as originals. So our current record retention schedule is called Schedule MLL1. It was issued in 2006, and it contains outdated record retention periods for certain types of records, such as employee retirement records. It's also very cumbersome because it's not searchable, so it's difficult to find records and their retention requirements. Next slide. So, New York State Health and Hospitals established a Records Management Governance Committee, and a subcommittee of that reviewed the LGS-1 to align it with the types of records that we maintain, such as medical records, personnel records, board of directors documents, finance documents, legal documents, IT, investigation and audit documents, and building and property documents, payroll and purchasing. And we did not include records that really did not apply to our operations. The subcommittee consisted of representatives from legal affairs, human resources, corporate compliance, and health information management. We also revised our operating procedure 120-19, which is the corporate records management program, and the LGS-1 will be attached to that. We also, as part of that revision of the operating procedure, made it much less cumbersome and easier to digest. So we are requesting adopting by the Board of Directors of New York City Health and Hospitals Corporation the system pursuant to Article 57A of the New York State Arts and Cultural Affairs Law, the applicable provisions of the retention and disposition schedule for New York local government records issued by the Commissioner of New York State Education Department, the LGS-1, as revised by the Systems Records Management Governance Committee for use by all workforce members in legally disposing of system records. It will be implemented upon approval of the Board of Directors.
Okay, any questions from board members? Okay, so let me then take it to a vote. All in favor, please say yes.
Yes.
Say no. Thank you so much, and thank you for all the
Thank you.
work that went into
Thank you.
putting it all together. Thanks. So let me move to the next one, which is adopting the attached mission statement, performance measures, and additional information to be submitted on behalf of New York City Health and Hospitals Corporation for fiscal year 2023 to the Office of the State's Comptroller's Authorities Budget Office, as required by the Public Authorities Reform Act of 2009. This is being presented directly to the Board of Directors today. Thanks.
Hi, I'm Matt Siegler, Senior Vice President for Managed Care Growth, and joined by Jeremy Berman, our Deputy General Counsel. The Public Authorities Accountability Act has several requirements on our organization, one of which is to go over our mission statement and make sure the board is aware, invested, and comfortable with it, and to track and present some of our key performance metrics that we track to follow our success in implementing that mission. So in this document, we have our system dashboard, which is the key set of performance measures that we track as a board and as a management team in our strategic planning committee, and then with the board in full. And the key measures here, as I think the board is familiar with, are in our strategic pillars of quality and outcomes, care experience, financial sustainability, access to care, culture of safety, and racial and social equity. So we will include this with your permission and include it on the public posting of our mission statement and performance metrics. And then as the board all knows, I'll just read aloud because it's just the greatest mission in American healthcare, and that's why we're all here. But our mission is to extend equally to all New Yorkers, regardless of their ability to pay, comprehensive health services of the highest quality in an atmosphere of humane care, dignity, and respect, to promote and protect as both innovator and advocate the health, welfare, and safety of the people of the city of New York, to join with other health workers and with communities in a partnership which will enable each of our institutions to promote and protect health in its fullest sense, the total physical, mental, and social well-being of the people. And then there are a series of questions that the board, I believe, has reviewed and the board office has filled out for you. And with your acknowledgement and endorsement of that mission and these performance metrics, we'll seek your approval to submit this to the state and post this as our public submission. So that is our request.
Questions?
Thank you for reading it out loud. It sounds even better than when you read it on paper. This is actually just a process question. It's for fiscal '23, but I note that the dashboard we're submitting is for Q2 '23. Is there a need for us?
I believe it's the latest version that the board has seen through a formal process. So, Jeremy, I'll defer to you if we need an updated version for the full year or if it's the measures that we are tracking.
And we've been doing this annually.
Okay.
And annually, we submit this dashboard on that same schedule, so.
Okay.
it
So this
kind
is like the 1 year update for them.
Yeah, and I believe our dashboard does have performance a year prior on all the measures, so it is a full year of reporting, even if it's mid-year reporting through Q2.
Oh, thank you.
Okay, so, yeah.
Just one more comment, and I'll agree. Reading it out loud makes it even more impactful. The dashboard specifically names racial equity, and so I'm just kind of curious, especially because there's so much conversation about equal versus equity. Curious if there's ever been any conversation about naming racial equity specifically, or saying equity instead of equality in the mission statement.
In the mission statement itself, I believe it is, built into our enabling statute in certain ways. In our more narrow version of it that is posted on our website and in our strategic pyramid, we certainly have had discussion at the strategic committee and others about the importance of equity versus equality and focusing it there. But in the underlying formal authority mission statement, I think it's an interesting discussion. I don't know the exact process for amending that mission statement to include it, but it's certainly a worthy thing if board members want to discuss it.
You mean that it's not included there, but it's included in the
Right, it's in the dashboard, but not named in the mission statement. So I was just
We
curious.
adopted the anti-racism statement. Did we do that, Michelle? Oh, sorry. Was there
I'm sorry, what was that?
the anti-racism statement that we adopted?
Yeah.
This is from our enabling legislation, is it not? So that's,
Yeah.
right. So the question would be how to change a word in the enabling legislation. How would one change a word in the enabling legislation?
Well, so this isn't exactly from our it's drawn from our enabling legislation, but if we were going to change our enabling legislation, that would require legislation, of course, yeah.
But this mission statement has to be resubmitted.
And it's resubmitted annually to the, I can't remember the name of it, but it's the authority that oversees the state authority that oversees public authorities.
But I should say that when we talk about strategic planning and you look at the pyramid that we have, it's written as what is it, social and racial equity as underpinning
Foundation of the pyramid.
as a foundation of everything. So, and that has been, I think, very impactful because it drives a lot of the conversation for every activity we do that is listed as a pillar. So part of the reason why this comes up in every committee meeting we have and when presentations are made is because we have it basically because we have that statement as the base of the pyramid.
I think I was just more
Yeah.
thinking if we have to resubmit this every year anyway, that
Like,
seems like
yeah.
an opportunity to update it based on the priorities.
So Andy, is this rewritten every year, or is it just the same language that we submit year after year?
Typically, is it, Jeremy, you're nodding yes? It is not typically rewritten every year, but it can be rewritten periodically. I think we would say, recommend that if that was gonna happen, it would go through the committee process with strategic planning to sort of like vet a change to a statement and then bring it to the board. This is really just this particular vote is sort of like resurfacing. This is right now our mission statement and telling that to the AAA authority that that's the case. But it can be revised. It certainly can be revised. I just don't know that the what's been brought to a vote here is like it hasn't been like certain edits haven't been considered, although they could be made here. But that's not actually the resolution I think that we have written. We could write it if people want to go down that path now.
Well,
Normally, it would go through
Andy,
strategic
let's
planning.
clarify a few basic questions. From what you're saying, even if this is from the authorizing legislation, we could change it for the sake of this issue, right? That's what you're saying.
It has-
And then,
yes.
so then the only question is,
What's the
do we
right
change
process?
it now?
Yes.
Or do we need, in order to change it, do we need to follow a different procedure with the idea that this is what's written now? And it does seem like this has a retrospective aspect to it, right? Because we're talking back, we're saying how it was. So that seems like a legal question of I mean, if we can change it now to fit the way our pillars are, we should change it now to fit our pillars are. If we can't change it to fit our pillars, then we should arrange to fix it how we accept pillars. So I think you have to rule.
Legally, the board could make a decision right now in any of those directions. I think the question is, the normal process would be to take a change to the mission statement, which it lives in a lot of different places. And normally, we would just sort of go through a vetting process for a particular wording change, then bring it to the committee, then bring it to the board. We could make a change right here.
But
I mean,
Andy,
we could.
because it is the base of the pyramid, I feel like, in a sense, we have adopted it. And if we could now just change to extend with equity instead of to extend equally, why not?
We have to put a motion.
Is that acceptable?
I think I was suggesting.
There's a
both.
resolution right on the table. Someone has to amend the resolution.
But
Yeah.
I was suggesting.
And is that
more-
the suggestion?
Right,
Like, I mean, I think we would have to agree on the actual words, exactly, the
Yes.
actual words in
Yes,
order to
yes,
do it. But
yes.
we could,
I was suggesting equity instead of equally, and also that racial justice or racial equity specifically be named.
so,
Let's parse that, because I think let's first do the grammar, Michelle, because you can't just change it to extend equity. Well,
Yeah.
maybe you can. I was thinking it has to be to extend
Equitably.
with equity, but maybe you can say, is that grammatically okay, to extend equity?
Equitably.
No.
Equitably.
I don't think the
Do-
grammar is
do we,
right. To extend
Equitably.
Equitably.
equitably. Okay, to extend equitably
Mhm.
to all New Yorkers. Say the second change, Michelle.
The
Do-
second change could go in a number of places, but I would imagine total physical, mental, and social well-being of the people, and to advance racial equity. It could also fit. I mean, I hadn't really thought about where to put it exactly ahead of time, but
think
it
that's
could
the
fit
tricky
in other
part.
places as well.
I think that's the tricky
Right,
part.
so-
do you need this approved? Do we need to get this approved today?
So let me just say, if we just vote on the resolution that's in front of you, this mission statement, which has been the mission statement that we've used in a variety of places, will just go as like the annual, along with some other things, as our annual thing to this authority at the state, and
For
we will
fiscal
say,
23, which is over.
and we'll just say, this is our mission statement. It could be changed tomorrow, it could be changed the day after tomorrow, it could be changed the day after tomorrow, it could be changed anytime. I think my one suggestion is, in general, I think for something that says foundational as a mission statement, to do it on the fly without the words really in
That's
front of
what I'm worried
everybody
about.
and thinking about it, I have some concerns about doing that. Because, you just have to, sometimes you add a word, but it somehow, when you read it holistically for the fourth time, you realize it actually is saying something you did not intend it to say. So I think that's the tricky
Well,
question.
Michelle, do you feel okay about this going forward and our making these changes for the next time? Is that acceptable to you?
I think if it probably makes sense to at least have some committee weigh in on the
Okay.
updated language, but I think.
So then let's do it that way if that's acceptable to everybody. Let's commit to changing it, and do we have a strategic planning? That would be the best place to.
We'll figure it out.
Calicia is
That's-
nodding. So we'll put it on the agenda for the next strategic planning. We'll change it then, and then we'll be done. Okay.
It makes total sense
Right.
to have these documents aligned, so.
May I suggest
Yes.
that Michelle sends her recommendations
Yes.
in writing so that
Yeah,
we're okay on the same page?
that can help, definitely. Any other questions or comments on this? Okay, so may I hear a motion to accept the resolution?
So moved.
All in favor, say yes.
Yes.
Opposed, say no. Thank you, thank you. Move to number 8 in your agenda. To read all of them. Authoring New York City Health and Hospitals, the system, to sign a 5-year license terminable by the system without cost with K&M Medical PLLC Group, doing business as mobile vascular physicians for MVP's use of 414 square feet at the NYC Health and Hospitals Carter, to 216 square feet at NYC H&H Kohler, 120 square feet at NYC H&H McKinney, and 125 square feet at NYC H&H Seaview as examination rooms in connection with MVP's vein care practice at initial rates of $47 per square feet at Carter, 57 per square foot at Kohler, 25 per square feet at McKinney, and $40 per square feet at Seaview, for an initial yearly fee of $74,859 for the 4 spaces, to increase by 3% per year for a total over the 5-year term for the 4 spaces of $177,000, $698. This is being presented directly, this was presented to the Capital Committee on September 11th, 2023.
Good afternoon. Thank you for the opportunity to present this. The overview of what we're trying to accomplish involves vein care for dialysis patients. Currently, those dialysis patients who require care for vascular services, they get the care off-site for additional costs and also inconvenience to the patients. The proposed resolution provides for the system to license exam rooms in 4 post-acute facilities where mobile vascular physicians will provide the vascular care on site. The 4 facilities that this proposal pertains to is Carter, Kohler, McKinney, and Seaview. These patients will be treated as MVP patients. MVP will bill third-party payers and use their own medical records and be solely liable for the care. MVP will then prepare the notes to that care, and it will be entered into our EMR, which is point-click care at the point of care transition. Not included in this resolution, but happening at the same time, is a service agreement that we are negotiating with MVP to treat our patients at bedside. The patients in this arrangement will be regarded as system patients, and our electronic medical record will be used to document all of the care rendered to the patient in the building. MVP will also bill third-party payers and will bill the system when the patient does not have insurance. The low dollar value of this agreement is below the threshold for board approval. A bit about the group. MVP is a regional provider of interventional radiologists, vascular surgeons, and other providers who are focused on particularly vascular diseases with a focus on dialysis access. To date, the group has served over 340,000 patients in 273 locations. Among the professional community, MVP is well respected among the providers in the community. A few examples of the procedures that are of interest and relevant to the dialysis population would be access creation, access surveillance, maturation of access, all related to receiving dialysis. MVP can provide care at our post-acute facilities. However, the surgical procedure itself would be provided in their vascular centers, which are located in Queens, Bronx, and Brooklyn. The license terms that we are proposing is one license with 4 locations. A Gouverneur, to highlight, is not included in the space license due to lack of suitable space. Gouverneur's patients will be able to have access to this care, but under the system agreement, and which will be done at bedside. And if they needed a surgical procedure, they would also be able to receive that service in MVP's office, which is off-site. So we're looking for a 5-year term that commences around December 1 of this year. The full market value occupancy fee was in the consideration slide. It's summarized here on the 5th slide, so I won't go over that. So in conclusion, we're seeking board approval request for authorizing New York City Health and Hospitals to sign a 5-year license terminable by the system without cause with MVP for the use of lease space in 4 of our facilities, which are Kohler, Carter, McKinney, and Seaview. Thank you.
Any questions from board members? Okay, hearing none, then all in favor, please say yes.
Yes.
Opposed, say no. Well, thank you so much.
Thank you.
We move to the next one. Just number 9, authorizing the New York City Health and Hospitals Corporation to sign a 5-year license agreement with Tasty Picks, Inc., number 2, for its use and occupancy of 2,500 square feet at NYC Health and Hospitals Metropolitan for a retail food operation at an initial rate of $30 per square foot or $74,400 per year, to increase by 2% per year for a total occupancy fee over the term of $107,723.63. Such agreement to be terminable by either party on 30 days' notice without cost. And this was presented directly to the Capital Committee on September 11th, 2023. Welcome.
So Christine Contreras is tied up at Metropolitan Hospital, and otherwise she would be here to make this presentation. So I, Jeremy Berman, Deputy Counsel, and Leora Yuntov, our Head of Real Estate, are here in her place. So this is part of our continuing program to catch up in the system around its different facilities for the lack of food vendors in the system. We lost a number of food vendors during COVID when they went out of business for lack of business, so we've come to the board fairly regularly with proposals for businesses to operate some kind of food service in the hospitals, and this is the latest. This is, the proposal is to give space to Tasty Picks, a company that we brought to the board about a year ago to operate at NCB, where Christine Contreras used to be the executive director. She became familiar with them and impressed with their performance, very kind of community-based, locally oriented food, and extremely inexpensive prices. At Metropolitan, there's been a long and difficult effort to find a food vendor. Several that we tried to negotiate with kind of dropped out of the process, and so Ms. Contreras looked back to Tasty Picks and asked them if they'd be willing to open a second location, and after some delay as family issues were resolved, they were able to say yes. And so the proposal is to rent a fairly small, I'm sorry, a fairly substantial amount of space, 2,500 square feet. And Tasty Picks will be operating a sit-down restaurant. We have in the materials I believe, the proposed menu, which is extremely modest in price. And so we're here to ask your approval for the proposed resolution.
Thank you.
I just want to acknowledge the thoughtful way in which you extrapolated to the rent, Mr. Rovitz. I guess it's not easy, you know, obviously, because these factors are
Yeah,
not typical, but I thought it was a very thoughtful process that was followed.
thank you.
Thank you. Jackie?
So what kind of food, at the restaurant, what kind of food are they having? Are they gonna have real healthy food or else I'm not coming?
No,
Organic or be vegan, what are you doing?
it's a healthy diet. I would say it's somewhat Latin in orientation. So there's you see on what slide is this?
We tried to put the menu up on the screen if it's visible, and the menus need to be approved by the CEO, and any increases are approved by the CEO. But the idea is that it meets all our healthy food guidelines, and we're working with Assistant Vice President Mercedes Redwood, who also looked at the menu, and
I'm sorry, you said the menu will be determined by the CEO?
they approved the menu and the prices, and Mercedes Redwood, who is not, I don't think she's in the room, but she's a dietitian, she also looked at the menu as well.
So it's kind of unusual that we've required that each of these food vendors put forward a menu. So we have their menu. That's the initial menu. If they're going to change the menu, then they need the approval of Christine Contreras. And similarly, the prices, which you see on nothing is more than $14. If they're going to raise the prices above just what's necessary to keep pace with CPI, again, they have to go back to Ms. Contreras.
And I think I noted in the memo that Sally referenced, there's no sugary drinks and.
Right. So there's a citywide healthy beverage initiative that we require that the vendors adhere to.
Right.
Okay.
I think you can go there safely.
Other questions or comments on it? Okay, so let me ask for a vote. All in favor, please say yes.
Yes.
Opposed, say no. Thank you so much. Let me move to numbers. I'm gonna read these two together. There's one presentation. So, number 10 is authorizing the New York City Health and Hospitals Corporation to execute a requirements contract with Gemco Electrical Contractors for a not to exceed amount of $10 million to provide general construction services on an as-needed basis at various NYC Health and Hospitals facilities over a term of 2 years. And this was presented directly to the Capital Committee on September 11th, 2023. And then number 11 is authorizing the New York City Health and Hospitals Corporation to execute a requirements contract with BA Global Construction Corporation Corp for a not to exceed amount of $10 million to provide general construction services on an as-needed basis at various NYC Health and Hospitals facilities over a term of 2 years. Also presented directly to the Capital Committee on September 11th, 2023. So,
Good afternoon, board members, Dr. Pagan and Dr. Katz. I'm Manny Sayas from the Office of Facilities Development. I'm joined here with Menji Endar, also from the Office of Facilities Development. As previously mentioned, this is a request for Gemco Electric and BA Global for job order contractors. And I'll hand it over to Menji Endar to take us through the presentation.
Thank you, Manny. Good afternoon. So job order contracts are contracts that we award based on a public bid where the bidders bid on a catalog of services with a multiplier. These contracts are typically used at our facilities for urgent or time-sensitive projects. The current contracts we have were awarded in 2019 and will expire at the end of this year. As you can see by the chart below, 2 of the 3 contracts are currently at capacity or close to capacity, and the third has about 3 million remaining, so it's about 70% used. So these contracts are needed. In terms of the procurement, two bids were open, one on May 17th of this year and the other on May 23rd, for two separate contracts, each $10 million, for terms of 2 years. The first contract opened on May 17th. Gemco Electrical Contractors was a low bidder. They are currently one of our JOCS electrical contractors. They were previously one of our GC contractors. Evaluations for both of those contracts respectively were 84% and 93%. Additionally, we found ratings and mocks for work completed with other city agencies, 2 excellent and 4 good. The second procurement was opened on May 23rd, and BA Global Construction Corporation was the lowest bidder. They are currently one of our JOCS general contractors, and the evaluations for their current contract is at 87.5%. BA Global is also a prime contractor on 2 separate projects, one at Kings County for a pharmacy and one at Woodhull for the facade. Slide. These are just the standard evaluation forms that we use. The first for Gemco Electrical, showing that based on our system, they're currently have a ranking of excellent. The second for BA Global, showing a ranking of good. Next slide. This is the MWB utilization plans for both vendors. Gemco has committed to a 41% MWB spend with the list of subs shown on the table below. And BA Global is a certified MWB vendor with New York City, so their spend will 100% be attributable towards MWB. Next slide. And the last slide, the resolutions again, just asking for the board approval to enter into contract with these 2 vendors. Thank you. Happy to take any questions.
Questions?
Just a quick question. We've been doing these in chunks of 10 million for a little bit. Is there a reason you might increase the amount, or that is really what we have an appetite for?
I mean, based on the utilization, historical utilization we've seen, 10 million seems to be the appropriate number. If, you know, as we continue to monitor it, we see an increase in demand, we will come back and ask for either increases to this NTE, or when we do a new procurement, we'll ask for a higher value.
Okay, thank you.
Just, I think on that point, and maybe Sally, this is what made you ask that question. The current contracts go to the end of the year, and we're pretty much at capacity already for BA and Carefree. So, is the, like, do the different contractors have different skill sets, or can they all do everything?
They can all do the same. So we typically have multiple contractors doing the same set of work. So for this particular pool, it's general contracting. So we normally have 3 contractors, 10 million each, that can do the same type of work.
Right. So if you're at capacity for the top 2, Walmart can still
Correct. Walmart has been correct. Yes.
Okay.
Yes.
Okay, so let's take it for a vote. All in favor, please say yes.
Yes.
Opposed, say no. Thank you so much. Look forward to seeing you often here in the next year. Lots of activities going on in the system. That's great. So item number 12, authorizing New York City Health and Hospitals Corporation to execute a contract with Gemco Electrical Contractors to undertake a renovation of the behavioral health units located on the 12th, 18th, and 20th floors of Bellevue Hospital Center to create a ligature-resistant environment for a contract amount of $12,779,569 with a 10% project contingency of $1,277,956 to bring the total cost not to exceed $14,057,525. And this was presented directly to the Capital Committee on September 11th, 2023.
Good afternoon. Once again, I'm Manny Saez from the Office of Facilities Development, joined by Oscar Gonzalez from the Office of Facilities Development, as well as Jean from the Office of Facilities Development, and Ms. Marcia Peters, Chief Operating Officer for Bellevue, who will begin this presentation for us. Thank you.
Hi, good afternoon. As a referral site for the mental health care for all of the other 10 public health facilities, Bellevue provides care for the underserved New Yorkers with many and diverse mental health issues. During the mid-1980s, we upgraded our behavioral health facilities on the 12th, 18th, and 20th floors, and at that time built out what was then state-of-the-art facilities, meeting all regulatory regulations. Over time, of course, regulations have changed, so we are now looking to upgrade this aging facility and aging units to better meet the needs of the population, but also to provide a safer environment for our staff. As a result, it has become necessary to perform a complete renovations of all inpatient behavioral health units at Bellevue in order to mitigate ligature risk and to provide a safe and space for patients, visitors, and staff. Now, just to be clear, ligature resistance means removal of any object, furniture, equipment, fixtures that could create a ligature point. And a ligature point is any part of said equipment, furniture, or fixtures that you can then loop or tie a rope, cord, bed sheet, or any other material to fashion a point of attachment that could lead to loss of life or self-harm. So these renovations should cover 6 inpatient units and will incorporate, amongst many other things, complete interior demolition of each patient room within each unit, replacing exterior windows with behavioral health grade compliant glazing, upgrading bathrooms and replacing existing plumbing fixtures with OMH ligature resistant approved fixtures, including sealing edges with pick-proof sealant, installing solid service sink bases and enclosures, upgrading finishes, millwork, and hardware to these new units that is compliant, and there are several regulatory agencies that we need to be compliant with. Some of these including continuous hinges and ligature resistance handles for all doors. This project will have no impact on the current bed count or result in an interruption of care. We expect to begin in January of 2024 with this project, and with the completion date being summer of 2025.
And next slide, good afternoon, Oscar Gonzalez here. And next slide just shows you the current state and what they look like today and what an anti-ligature environment would look like tomorrow when the job is complete. We went ahead and procured a contractor, so we proceeded back in April 2023. 4 contractors attended the pre-bid walkthrough. In June of 2023, we received 4 bids. And by August 2023, we had a pre-award meeting where we held with Gemco Electrical Contractors the lowest when we held them the lowest responsive and responsible bidder. We sourced the procurement via public bid. Gemco was deemed the lowest responsible bidder. They also provided a 32% utilization plan. Out of that utilization plan, that comes out to about $4,071,747. Those are the subcontractors there that are listed that will be receiving that amount out of a total amount of $12,724,208. Gemco, as the previous resolution, is on our current pool of JOCS contractors. They were on our previous JOCS contractor as well. They've always rated very high for us when it comes to their performance, one at 84%, the other at 93%. And we have pulled some of their performance evaluations from our MOX vendors, and we found their ratings to be, 2 of their ratings to be excellent and 4 of them to be good. As mentioned earlier, the construction is expected to start at the beginning of 2024 and completing in summer of 2025. The next slide shows you the performance evaluation assessment that we do, and we found this event to be excellent. And the last slide shows you the project budget and construction of $12,779,569 with a project contingency of 10%, which equates to $1,277,959, to a total amount of $14,057,525. The funding is currently available and is being authorized by OMB at this time. And with that, we'll take any questions.
Any questions?
I don't really have a question, just a small point. You're doing 6 units for $14 million. You might want to add the number of rooms that translates into, because it doesn't sound like a lot, but I think it is.
Yes. So each one of the unit holds about between 25 to 30 patients. And then in addition, we have treatment rooms, we have medication rooms, we have offices for the clinical staff, we have recreation rooms for the patients, et cetera, et cetera. We can give you a breakdown of the number of rooms.
Thank you.
Thank you.
Just a little bit about the kind of trends you expect in terms of the patient flow to fill up those rooms.
Yeah, well, we have patients waiting. Our CPAP, which is the psychiatric emergency department, is always filled. Unfortunately, we sometimes have to go on diversion because of it, but we try to accommodate and treat as many people who come to our doors as possible.
Thank you.
Thank you.
See, so you say there will be no impact to current bed count or is that because you have other space that you can
Great
move
question.
patients to?
So prior to this project where we are asking for funding, we started an in-house project. So we actually have one unit that's being used as a swing space. And as we complete one area, we move another area in. And what I think it should have actually said, it's no impact on the actual number of beds, certified number of beds. So we do have a swing space now, but the certified beds will not increase once the project is completed.
Okay.
Okay, thank you so much. So let me then ask for a vote. All in favor, please say yes.
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 Opposed, say no. So the resolution carries. Thank you so
Thank you very much.
Ms. Hernandez Piñero,
Yes.
yours is next, number 13.
Okay. Okay. It reads authorizing the executive director of MetroPlus Health Plan, Inc., MetroPlus of the plan, to negotiate and execute a contract with Health Edge Software, Inc., Health Edge, to procure a new replacement modern core processing system for an amount not to exceed $109 million for a total 12-year contract period with 2 5-year renewals subject to future approval by the Board of Directors of the New York City Health and Hospitals.
Good afternoon. I'm Talia Schwartz, CEO of MetroPlus Health Plan. I am joined here today by Steve Stein-Cushman, our Chief Counsel, and by Ganesh Rambartan, our Chief Information Officer. Ganesh?
Good afternoon. So we're seeking a 12-year initial contract with a Health Edge platform to replace our current core processing system for an amount not to exceed $109 million. Next slide. So what is the core processing system? A core processing system is the engine of every payer organization. It's a central place where all of the organization's information converge, and it's used to drive business decisions and actions. It contains our member and provider demographics and is used to track eligibility information. It stores various health benefits by lines of business. It stores the contract terms used to pay providers, and utilization and care and disease management also lives in the core processing system. Next. So why do we need a new system? We have been on this platform for over 30 years. Our current platform is built on outdated technology, is inflexible and difficult to use. It takes time and effort to maintain and enhance a system that produces close to 9 million claims a year. In our current system, we can only auto-process about 72% of the claims that come in. Health Edge customers regularly achieve over 90% auto-adjudication rates with at least 99% accuracy. We have challenges supporting some of the complex New York State requirements natively, leaving us with no options but to create manual workaround solutions. These manual workaround solutions have the potential for human error, leading to inaccurate payments on reprocessing and higher administrative costs. Staying on the current platform severely limits us in supporting our strategic goals. Newer core processing system platforms are also more cost-effective. Our current contract with the existing vendor expires on December 31st, 2024, with the ability to extend through 2026. Remaining on the current platform is not a viable competitive option for MetroPlus Health. Next.
So what do payers expect of a core processing system? The ability to launch new products or enhancements on our current system can sometimes take up to a year. Payers want to be able to launch products quickly. We have to spend time developing connections to other systems and come up with workarounds. Payers expect to be able to easily connect to other systems. We currently have challenges meeting regulatory demands without massive manual efforts. Payers expect a system that will enable us to be compliant with regulatory mandates. Next. So we conducted an RFP, and on the RFP process, on the left are our minimum criterias. In the middle shows our evaluation committee. Our executive staff and subject matter experts were heavily involved with the evaluation and the ultimate selection. On the right breaks down our scoring criteria. We also had 2 phases of scoring, including a deep dive assessment and best and final offer with the 2 finalists. Next. For the selection process, we had 6 vendors responded to our RFP. 4 vendors met the minimum qualifications to proceed. 2 vendors made it to the finalist round, and Health Edge ranked most favorably by the MetroPlus Evaluation Committee. Our current core processing system is a disjointed combination of systems which don't seamlessly talk to each other. Our systems for Claims Engine, CM, and DM and billing platform will converge into a single platform. We have the main Claims Engine used to maintain our member and provider demographics, data, and process claims. We have a separate system which is used for utilization management and authorizations. And we also have 2 homegrown systems for disease and care management and processing premium billing. The future state will have a single end-to-end integrated system that incorporates all of these functionalities into a single platform. From the single platform, we'll have member and provider information, contract setup and analytics, and reporting capabilities directly within the system. Claims processing, utilization, and care and disease management also within the system. The unified platform will feed into our Salesforce system from a single source of information, which our customer service team will continue to use. Next. So this is a graphical representation of the expected enhancement that we'll get from Health Edge, and I'll speak to it on the next slide. So next. What are Health Edge's strengths? They have a user-friendly, intuitive design that makes it easy to learn and allows for quicker turnaround times for configuration changes. The technology is well positioned to bring MetroPlus into the future. The technology design allows for the ability to integrate with other systems, including Epic EMR. Health Edge has over 11 years of experience in the New York Medicaid market, and they also have all of MetroPlus's current lines of business. Nearly 25% of Medicaid managed members are on their medical management platform that's part of this core processing system. They have over 105 clients with over 76 million covered lives and 8 New York plans on the Health Edge platform, with over 550,000 total New York members currently living on the Health Edge Claims Engine. As part of the procurement process, Health Edge has completed the vendor responsibility form, DOI's vendor name check, the EEO is in progress, and Health Edge has committed to a 10% MWBE goal on the implementation component of the project. Next. Under the proposed agreement, Health Edge will commit 10% of its implementation to Impressive Health for project management, and Impressive Health is an approved and certified New York City MWBE. So this is a very high-level timeline for us to go live with the new core processing platform. As you can see, we will need to continue to support the day-to-day operations of our existing system on a parallel track during implementation. We expect that we will have multiple go-lives in 2025 as part of a phased approach. As we continue to work with the vendor, we will obviously tighten timelines.
So this is the funding slide. Where is the money going to come from? So the entire cost of the initial implementation for the first year will be categorized as capital expense, capital asset, and it will be funded from the plan's unassigned surplus. The cost of the initial implementation is $19 million out of the total of $109 million. and our annual system spend will be included in the MetroPlus administrative loss ratio, also known as the ALR report. So the funds are currently available to the plan to be utilized for the initial investment.
And to put it in perspective as well, this is 1/4 of 1% of our annual revenue.
Oh, wow.
Next.
Thank you so much.
So to reiterate, we're seeking a 12-year contract, 2 years of implementation, 10 years of production, with 2 5-year renewal options, a not-to-exceed amount of $109 million for the initial 12-year contract term, not including the 2 5-year options, which will be negotiated and brought back to the board in the future. And expected contract start date is around March of 2024. Thank you. Happy to take any questions.
Okay.
I was just trying to understand the funding, Talia, that you mentioned. So the 19 million is for the whole implementation period?
It's implementation and the first year of operations, which will
And the first year.
And the first year will be capitalized as 19 million, and beyond that it'll be expensed.
And it'll be expensed. So it'll be 90 million over the 9 years, basically. Right. Okay.
Yes.
Thank you.
Sally?
I just had a couple of quick questions. PowerStep is your main processing system. How many plants currently use PowerStep?
It is getting smaller and smaller in the day, by the day. I think there currently have 6 remaining and extremely small plans.
Okay. And you mentioned that there are requirements, like New York State requirements that we currently can't meet. Would you have an example of a request that was made?
Yeah, so many a times the state sends retroactive rate adjustments, and the volume, especially since we've taken on behavioral health, has been significant. At one point, we actually broke the system trying to run all of the processes, so we had to pause and batch them so that we can be able to complete them. So it is a significant amount of manual work that has to be put into any request that comes from the state.
And my last question is just because I know the answer to this, and I think it's an impressive answer. The amount of time that you have invested when you started with the concept and getting to this place, how much time do you think it's been?
Yeah. We took our time. We wanted to make sure that we're making the right decision, that we're really digging in. Sometimes you don't really know what you get until you start implementation, and we couldn't afford to be in the situation for something that is the engine that moves the company. So it took us over a year to actually do this RFP with external consulting support to make sure that we really looked under the hood ahead of making the decision.
Thank you.
The question I kind of follows from Sally's actually, specifically around the state, requirements. And with the Medicaid waiver amendment coming and the focus on social needs, I was just curious if and how you expect the system to be useful in integrating health and social needs and the data requirements that are going to be coming from the state for managed care for the waiver.
Yeah. I think historically, what we've seen is that we're ingesting more and more and more data. So it used to be just basic data, right, that we were looking at, and this is no longer the expectation, which means that we have to process larger quantity of data. So we have data coming in as part of kind of the regular course of business. As Ganesh mentioned, we also have adjustments that are made retroactively, and those are not planned. We get the request or the mandate from the regulators, and we have to execute in a given period of time. So we have a growing amount of data and claims that are being processed, including social determinants of health and other types of information, including racial and ethnical backgrounds. So we're ingesting all of that, and we're doing retro processing. So that results in significant volume at any given time, and we need a modern system to be able to capture all the information, report on the information, and make it valuable.
Okay, any other questions or comments? Okay, on that note, then let me take it to a vote. All in favor, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much. Thank you
Thank
for
you.
all the work you do. It's very impressive how MetroPlus is evolving and all the tools that you are putting at the disposal of all the staff. So that's great, and thank you.
Thank you, we appreciate it.
And thanks for the leadership too on the board side and from Sally Hernandez Piñero, of course.
Absolutely.
So let me move to number 14, authorizing New York City Health and Hospitals Corporation to execute a contract with IVCI LLC for audiovisual design, installation, and support services for a term of 5 years with two one-year renewal options exercisable only by the system for an amount not to exceed $65 million. And this was presented directly to the Information Technology Committee on September 11th, 2023.
Thank you very much, and thank you for having us here today. I'm Kim Mendez. I am the System Chief Information Officer, and I am joined today by Jeff Lutz, who is our System Chief Technology Officer. I'm going to give just a general overview of the proposal that Jeff will be presenting. This is a system-wide standard solution for audiovisual design, installation, and support services that then our facilities and central office could leverage if they have a budgeted project to address either upgrades or new needs for audiovisual support for conference rooms, command centers, training areas, etc. So Jeff, I'll turn it over to you to review the RFP and our final proposal request.
Thank you, Kim, and thank you, Board, for the time this afternoon. So as Kim had mentioned, to give you a little bit of background of where we are today, many of our locations across the corporation that are large conference rooms, auditoriums, training rooms, and the like are today have outdated technology. It's not standard. It's difficult for us to work within there and leverage them to their full extent. And this provides us a vehicle now to when the need arises and the funding is there for the facilities to be able to leverage and create now a standard environment, a modern environment, and a sustainable environment for us that also allows us to integrate in with our existing technology today, making it a seamless experience for our users across the corporation. So we've gone through, and the other piece that this will allow us to do now is take what was previously a two-step process for design, and then to do the actual solicitation and implementation and into one, and it'll save us cost on that design step. IVCI has been doing this since 1995. They are a leader with these AV services, working with clients across the globe, including Elevance Health, White & Case, and the EPA and Uber. They also partner with the technologies that we use today in Cisco and Crestron and Poly. And as well, IVCI is a partner that has been working with health and hospitals for the past 10 years, designing and implementing and supporting many of the rooms, including the boardroom and our emergency management rooms. Next slide, please. Our RFP, we were looking for evaluating not just experience, but ensuring that they have the technical resources as well and certifications in order to do the design and installation and support of these rooms. We had a committee that was varied across both clinical, administrative, as well as IT and facilities, pulling in different users that have different experiences and different needs to leverage these rooms. And our criteria for evaluation included experience, the technical proposal, cost, as well as MWBE utilization. Next slide, please. And the initial RFP was released in January, posting both to City Record as well as 14 vendors directly that we had previously worked with the final selection being made in July for IVCI as the highest rated proposer. Next slide. And they've committed to 35% utilization of MWBE, leveraging partners for both labor and goods to help perform some of these services that are listed here. And their evaluation, they've been a very good partner and have been very good to us and good working relationship. In summary, EITS is seeking approval to enter into a contract with IVCI LLC to provide all design, installation, and support services for audiovisual equipment and services not to exceed an amount of $65 million. The contract would start in 2024 with a term of 5 years and 2 one-year renewal options. And there is a termination for convenience exercisable at the discretion of New York City Health and Hospitals. At this time, I'm willing to take any questions.
Questions? Yeah.
Yeah. ICVI has been working with H&H for the past 10 years.
Yes.
And, but we have this $65 million of unmet need. So in what capacity have they been functioning for the past 10 years? I mean, there's
Yes.
such a gap.
Wait, yes, but, so they actually were the ones that helped to build out all the rooms here in 50 Water as well as 55 Water, and the training as well as the previous boardroom at 125 and the emergency management rooms that were done across the facilities. The reason for the gap really comes down to more of the ability to fund in a project to go and address these rooms, not from our lack of want to engage IVCI in order to do these services at that time.
Okay, thank you.
Okay. Any questions or comments on this one? Okay, hearing none, then let me take it on a vote. All in favor, please say yes.
Yes.
Opposed, say no. Thank you so much.
Thank you.
Let me move to number 15, authorizing New York City Health and Hospitals Corporation to execute a contract with Experian Inc. for EDI clearinghouse services for a term of 3 years with 2 one-year renewal options, exercisable only by the system for an amount not to exceed $25 million. And this was presented directly to the Information Technology Committee on September 11, 2023.
Hi, good afternoon. I'm Margie Carlin, Chief Revenue Officer for the system, and I'm here to teach you a little bit about claims clearinghouses. So according to the HIPAA Administrative Simplification Regulations, a healthcare clearinghouse processes or facilitates the processing of health information received in a non-standard format or containing non-standard data content and converts it into standard data HIPAA-compliant elements. A claims clearinghouse can kind of be viewed as that middleman between the healthcare provider and the health plan, facilitating the exchange of electronic data. So an effective clearinghouse will provide specific payer rules and checks the claims for errors against those rules. We call that scrubbing or cleansing the claims. The clearinghouse will provide HIPAA-compliant data sets and standards for eligibility checking, claims processing, claims inquiry, authorizations, and remittances. Electronic connections with various payers for all of these transactions, and some related services such as address verification or payment propensity scoring. Clearinghouse services save organizational costs by minimizing the individual rules that the organization must maintain, enhances information security, minimizes the number of individual connections that the organization has to maintain on their own, maximizes the electronic submission of claims, the electronic transmission, and ultimately increases the speed to payment. Currently, Optum provides the clearinghouse services to New York City Health and Hospitals through a variety of their product offerings through their legacy Change Healthcare organization. The products that we have are Clearance, Assurance, Coverage Insight, and there are a couple of others. The Optum contract was awarded through a best interest contract award during the Epic implementation. The contract was awarded to Change Healthcare in 2018. In October of 2022, Change Healthcare was purchased by Optum, which is a subsidiary of United Healthcare. The current contract expires in October of 23. The current contract is a 5-year, $29 million contract with Optum, and the cost for these services include monthly and per transaction fees. In terms of the procurement and the RFP, the minimum criteria that was set forward in the RFP was at least 5 years in business, experience with New York State Medicaid, Epic integration and experience working with similarly sized networks, and annual revenue in excess of $25 million. The substantive criteria for the RFP were needs fulfillment, cost, quality of the products and services offered, and reputation and references. There was a pretty comprehensive evaluation committee with representation from EITS, Revenue Cycle, patient access, patient accounts, and the facilities, including one of our facility CFOs. In terms of the actual procurement, thank you. In November of 22, the RFP was posted on the city record and sent directly to 8 vendors. In December of 22, there was a pre-proposal conference held with 7 vendors attending. In January 13th was the proposal deadline. There were 7 proposals received. On May 24th of 23, the evaluation committee submitted the first round of scores. There were 4 firms shortlisted across 2 scopes of work, so we divided the RFP up into multiple scopes and then consolidated them into 2. Between June 8th and June 14th of 2023, the shortlisted firms conducted presentations, and then on August 23rd, 23, the reference checks were completed and the final pricing and scoring was submitted, and Experian was the highest rated vendor across all scopes. Experian is our current vendor for merchant services, which means they provide credit card terminals and the connection for processing credit card transactions between New York City Health and hospitals and the banks. And the performance in this area is quite strong. Experian has provided services to over 60% of the hospitals in the United States for revenue cycle management, identity management, patient engagement, and care management solutions. Their strength comes from a heritage of their legacy healthcare companies using deep data and analytics to help clients improve in today's value-based environment. And in order to support the 240 Epic clients that Experian has, they've hired former Epic employees and dedicate multiple resources to ensure that their products complement Epic and help automate the workflows. These individuals focus solely on Epic integration, and the reference checks were completed and successful. In terms of the vendor diversity due diligence, the vendor diversity team performed an availability and capacity analysis by identifying each potential scope of work available for subcontracting within the solicitation and researching the MWBE directories for each scope of work. Only one MWBE firm was identified that could perform a subset of a scope of work. Accordingly, there was insufficient availability and capacity to set a vendor diversity component percentage for this RFP. As part of the ongoing due diligence, the vendor diversity team had extensive conversations with the top 3 scoring vendors to double check to ensure that no scope of work for subcontracting was missed. We wanted to see if there was anything available. The scopes of work were reviewed, and none of the vendors planned to subcontract out any portion of the scope of work related to this solicitation. However, all were open to using diverse vendors should any subcontracting opportunity arise during the terms of the contract. Each phase of the project is expected to be in short, discrete phases, which will be fully self-performed by in-house employee teams. Additionally, the vendor The vendors shared their internal DEI programs and policies. Experian, in particular, has a robust national supplier diversity program and works extensively with national certification entities such as NMSDC and WBENC. So Revenue Cycle Services is seeking to award a contract to Experian to provide full EDI clearinghouse services at a not-to-exceed amount of $25 million. And the requested contract terms are 3 years with 2 one-year renewal options at the discretion of New York City Health and Hospitals. The anticipated start date is July 1st of '24.
Any questions on this one?
Just a quick question. Were they the lowest priced bidder as well, Experian?
It's a really good question. I'm not sure that I know. I'm looking, I don't have any of my friends from procurement here. I'm not sure.
Okay, you can get back to me.
Go ahead.
Thank you for the lesson. It's not totally clear, but what is non-standard, and like how much of the information we get is non-standard, and what does that actually mean? I don't know.
So claims, HIPAA has very clear and complicated rules around how claims are submitted to payers, how claim status requests are sent, how remittances come back, and think about, a form and what discrete data needs to be represented by what codes in what form. The clearinghouses help take the data from the EMR and translate it into these codes and I think of codes and dots and all kinds of things into the exact electronic format that the payers require.
Okay. So it's all an electronic, so we enter the data into the EMR, and if it's not.
Right. We enter the data onto the EMR. We send it in, and more or less, the form is called the UBO4. So we send it in this UBO4 837 institutional claim format out to the clearinghouse. The clearinghouse then takes payer-specific rules around those and applies it to what we send. So it's not changing any of the data. It's reformatting it so that it's compliant with their requirements.
And so they have a lot of security around it and everything like that. But this wouldn't be every record that we have. It's only some are non-standard and some are standard. Is that right? Or is every interaction we have?
Every interaction has to be in a standard format with standard code sets.
Right, but every interaction we have would have to go through the clearinghouse, or some are already standard, I guess is my question.
Theoretically, some are already standard, but we do send everything through the clearinghouse. That way we only have to maintain one electronic connection.
And this is a clarification, that the 25 million not to exceed covers the 2 extensions also, or it's just the first 3 years?
5 years.
It's for the full 5. Thank you.
Any other questions? Or? Okay, let me then take it for the vote. All in favor, please say yes.
Yes.
Opposed, say no. So resolution approved. Thank you so much.
Thank you. And I'm staying for the next one.
Stay for the next one. So our last one, actually, it's authorizing New York City Health and Hospitals Corporation to extend its current contract with Optum, Inc. for an additional 12-month term for an amount not to exceed $5,862,541. And this was presented directly to the Information Technology Committee on September 11th, 2023.
Okay. So as I noted in the last presentation, our current clearinghouse services are provided through Optum and their legacy products through when they purchased Change Healthcare. The Optum contract was awarded through a best interest contract during the Epic implementation. The current contract expires in October of 2023. A 12-month extension through October of '24. which is when the new clearinghouse vendor is anticipated to start. The new clearinghouse vendor is anticipated to start in July of '24. We built in the overlap as a contingency, just to ensure that all things go smoothly. This is a pretty big implementation for us. Listening to the MetroPlus presentation, I was getting a little bit of flashback or flash forward. So we just want to make sure that in case there are any delays that we're covered. And it's absolutely a requirement for the revenue cycle to move, that we have a clearinghouse to process our claims. So Revenue Cycle Services is seeking to extend the current contract with Optum by 12 months at a not to exceed amount of $5,862,541 to allow time for vendor implementation with the newly selected clearinghouse.
Okay, any questions on this one?
Just a comment. So the new vendor actually is at a lower cost.
It is.
This is a year for 5.8 million.
It is.
Right. So maybe that helps.
Every dollar.
Did Optum bid on the other contract?
They did.
Okay, any other questions on this one? Hearing none, then all in favor, please say yes.
Yes.
Opposed, say no.
Thank you.
Okay,
Mr.
so.
Chair, just a quick minute to again say, as I said before, how big a part in our success Margie has been. I mean, the services that we provide just don't exist unless there's enough money. And Margie has been amazing, an amazing partner for people, understanding what the costs are, what the expenses are, so that people can do the right thing. She explains it in terms people understand, and so it makes a huge difference and is a huge part of our success. So thank you, Margie.
Thank you.
I appreciate the opportunity. Oh, boy.
Thank you. So now we move to the President's report. Dr. Katz?
Okay, this has been a long meeting with a lot of agenda items, and I have a 11-page report, which I am not going to read at this point. I'm
Highlights.
tired, you're tired.
We have half an hour.
But I have to put it in because there is amazing stuff that goes on in health and hospitals, and I want it to be part of the record. So I'm just going to hit a few of the highlights and hope that at a more relaxed moment on the couch, you will all read through the report so that you can appreciate, you know, the many phenomenal people at health and hospitals. Starting with the asylum seeker work, where whatever the controversies have been, what our North Star is taking care of people. We're here to take care of people. We are not engaging in many of the other debates. They are complicated, but our bottom line is we're here to take care of people. That's what Health and Hospital does. People need a home, people need food, people need immunizations, people need to be connected to healthcare, and that's what we're going to do. And we're going to work very hard to make sure that that's our role. And I'm very proud of the services, and whatever the controversies are, when you talk to the people who are getting the services, they are uniformly grateful and feel they've been treated with respect. And that is the health and hospital tradition. We have a large number of hospitals who were listed in the Best Hospital Award for U.S. News and Report. All of our skilled nursing facilities made it to the Newsweek nursing homes of 2023, and I just have to say, as somebody who's tried to champion the public sector all my career, Seaview, the #1 nursing home in the state. Right. So for anyone who believes that the public sector can't possibly compete with the private sector and that it's always going to be second rate, we are the #1 choice. 6 of our facilities were certified by Plaintree International for excellence in person care. There's a nice list on page 4 the amazing top Latino doctors who were listed based on 32 states and 60 specialties listed these doctors as top Latino doctors. This is top across the nation, and we are incredibly proud of them. Our peer academy, I think that's another, really innovative thing we do. We have an academy for people with lived experience with mental health or substance use conditions, where we train people to be peers. It's a great way of connecting people with a middle-class job, union benefits, so it's good for them. It's good for our clients because connecting with someone like you is very much needed. And it also recognizes that a lot of what people who are in recovery need is not just psychiatric help or psychiatric nursing or medications, but it's connection and it is meaning, it's relationship building. And for that, you don't need to be a doctor or a nurse. You may be more impactful as a peer. Our ACO won shared savings for the 10th year in a row. We are addressing, some of you may remember at our annual meeting at Staten Island. Remember, people were upset that there were not opiate settlement dollars that were going to Staten Island. And so we were determined to be part of the solution of that. And Vanderbilt opened a buprenorphine clinic to provide comprehensive treatment for individuals with addiction to opioids. So that's not only a good thing, but I think shows that the power of having a public meeting, borough by borough, and trying to address the issues that people raise. I think with that, I'm going to allow you to read the rest of the services. I need to read, though, the contract actions because I want them to be part of the public record. So to house the families of migrant asylum seekers, the rental of a hotel at 29 Ryerson Street, Brooklyn, New York, from Sulla Ryerson LLC for 24 months from September 15th, 2023 through September 16th, 2026 for an amount not to exceed $65,514,018 with a 21 minimum term, and to provide security services at the Herc sites. We've contracted with the security service provider Mulligan Security LLC for a period of 5 months in an amount not to exceed $23 million. An RFP for Herc Security Service was issued. We expect to request approval of award from the board for such contracts in October. Such contracts will replace this emergency contract. Thank you very much.
Thank you, Dr. Katz. Any questions for Dr. Katz?
I just have a comment.
Yes. Go ahead.
So, I don't know if people are aware of how proud H&H should be of the peer psychiatric program that we have. And it's something that I am not sure how many people have modeled after it. I know how long we've had it. I know Kings County had it, but it is something that we should definitely make sure in the health community, behavioral health especially, that they are aware of it and the success of the program. It is pivotal. It's kind of the same model that's been used with opioids and, having the counselors, but the psychiatric care and people working, that was a brilliant move for H&H, and I'm not sure everyone's aware of it.
Thank you. Thank you.
Sadly needed expansion.
Dr. Morse.
The question I was just going to ask actually was just about respiratory viral season. Of course, I have to ask. And was just curious if there's anything you could share about how you're thinking about distributing free COVID test kits for respiratory.
So we definitely have test kits, and we are continuing to distribute them. We're going to be doing vaccination, as you know, in collaboration with your great department. We're happy so far, not much flu, not much RSV, slowly increasing COVID numbers, but not serious COVID cases continuing. But we want to have, with the first week of October, we want to make a big push for flu, again, with you. Is there anything you want to add from your point of view?
Just getting ready.
Yeah.
I think that's it, the big
How are you
push.
gonna distribute the vaccines? Are they gonna be the hospitals, the Gotham Center?
Yeah, it's a fascinating issue, and Dr. Morse may have her own view. The federal government made what strikes me as a slightly surprising decision to give half of the supply meant for uninsured persons to commercial pharmacies. I mean, the good of this, and I think the positive, was meant to say they're on many corners and they're in people's neighborhoods and people are going to pick up their meds and do that. But it does mean that, I mean, we're used to getting large supplies, and all of the public sector is getting only about half, which means we can't vaccinate everybody who is going to be an uninsured person, because we only have half the supply for uninsured persons. So it will be some mix. I mean, I think the natural separation is, you're a patient of mine, I'm going to vaccinate you at my clinic. You're not a patient of mine, we're going to say, go to the pharmacy near you. But if someone can't, it doesn't work, and you're at one of our Gotham sites, we're going to vaccinate you. So it's sort of, we're not going to turn anybody away, but we're also not unlike COVID. We're not going to be out there saying, come to us for a vaccine, because we won't have the supply.
But how will uninsured people know?
That is a very good question. That is why many of us were surprised, because we would have said, shouldn't you give all of the supply for uninsured people to the places that uninsured people go, which are not just us, but us, the other FQHCs, the community-based organizations, but that was not the federal decision made. That's not a New York, that's a national decision that was made on how this will be done.
Does that mean that the people who have the entities that have the vaccines for uninsured can't use those vaccines for people who are insured?
My understanding is the way it works is, if you go into CVS and you're an insured person, they're gonna give you the vaccine and charge the insurance. If you are an uninsured person, then they will still give you the vaccine, which they otherwise wouldn't. Right. So if this program were not in place and an uninsured person went to CVS, they'd say, I'm sorry, we can't give you a COVID vaccine, because they've been given a supply. So they have to keep track.
But they can't use the uninsured vaccines for insured.
I don't know whether it's a literal thing. It's a tracking. It's right. It's
So if they got no uninsured patients, they could use all their vaccines.
I would hope
they wouldn't get paid, though. They have to be able, in order to get paid for right now, the total supply is not constrained, or at least it's not, so it was not supposed to be constrained, but actually it is constrained, because at the moment, the suppliers are having trouble getting out enough vaccines. So that's why a number of sites don't have the vaccine. But ultimately, it's not supposed to be that there's not enough vaccine. There's supposed to be enough vaccine. But where you go, right, so the issue for us is that if every uninsured person came to the public sector would have to pay 300, I think isn't it 3, what are they charging? Do you remember?
140?
It's 140?
140.
Maybe it's the RSV that's in the 300 one. So we would have to be buying at $140 dollars for that vaccine. While if they go to if half the people come to us and half the people go to the pharmacies, then everybody's going to get vaccinated. If 2/3 of the people come to us, we would, after we use up the slots we have, we would have to buy at $130 the vaccine.
Yeah, that doesn't make any sense.
so that's why we're not putting out a big shirt that says, come to us, we'll give you the vaccine, but rather we're saying, we'll take care of our patients. You call us up and you say, I want a vaccine, you're not a patient. We say, oh, have you thought about going to your nearby pharmacy because they have vaccine for you?
So we're not talking about the flu shot now, we're talking.
We are not talking about the flu shot. We are only talking about the COVID. Flu shots are provided free.
Mr. Nolan?
Has the supply that you, if you've received them already, have they been sent to the city hospitals for distribution or not yet?
Not yet. There,
How
but
far
that's
are we
been
away, ballpark figure?
well, I think ballpark was last week.
It changes from week to week.
Right,
Because I
and
happen to
so-
call Jacoby, 2 blocks away from my house, on the way down. And I was told, we'll get back to you. It's very unusual for Jacoby not to get back to me, and it's 4:30. So I don't want to put them on the spot. If they haven't gotten it in maybe a week or two, and it's easy for me to get it there, then I'll wait a week or two. I can wait.
Multiple people, if you tried calling a pharmacy, you wouldn't, at least as of 2 days ago when I was talking to someone who was calling around, there were 0 pharmacies in New York City that had it.
So it's early.
No, lots have it now.
You think, well, 2 days ago, this person of mine called and found out they could go to New Jersey. But maybe they were not as, they literally called me and said that they could get an appointment at Hackensack, should they take it. So
The chain pharmacies do have it. It's the independent pharmacies that I think are a little bit.
Yeah, CVS
Interesting.
in my,
Someone who
is,
just got it.
advertising it.
Yeah, exactly.
it's, let's agree, it's variable and chaotic.
Okay, anything else? On the control report? Okay, so, committee and subsidiary reports, the committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Are there any questions or comments about the reports? Is there any old or new business to come before this board? Hearing none, the board meeting is adjourned. Thank you.
This meeting is no longer being recorded.